Good afternoon and welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and then also please remember to fill out the program evaluation. And if you could give the CME committee any ideas that you might have in regards to future topics or future speakers. Our topic today is diabetes, and our speaker is Dr. William Sivitz. I would be hard-pressed to think of anybody more qualified to present on this topic. Dr. Sivitz is the director of the clinical research, or the Diabetes Clinical Research Center at the University of Iowa, where he's also a professor in the Department of Endocrinology and Metabolism, and he's also the division chief at the VA in Endocrinology and Metabolism. And we're extremely pleased that he was able to brave the elements and come over today to provide us with an update on diabetes. And so please welcome, or join me in welcoming Dr. Sivitz.
Hey, thank you. Can you all hear me okay? Yeah, I'm very impressed with this auditorium. I can't believe how modern this looks. I haven't been here before, so thank you. So we'll talk about diabetes today, update. Okay, so the objectives, as you saw before, we'll briefly go over some background and goals, and then talk mostly about drug therapy and the appropriate use of insulin. Very briefly, the pathogenesis. This is about as simple as you can make it, but actually summarizes it pretty well. Type 1, as you all know, no insulin. Presents abruptly, but not always. And older people with type 1 can present very slowly, sometimes over 5 or more years, with a gradual onset that all the world looks like type 2 till it identifies itself as type 1 by the absence of insulin, and worse yet, sometimes as DKA. Type 2, as you know, insulin resistance associated with the impaired but not the absent ability to secrete insulin. The other thing that we appreciate more and more as we go along is that type 2 diabetes worsens with time, probably because the insulin ability to secrete insulin does not keep up with the insulin resistance. So what comes first is still somewhat debated, but it seems clear that the worst defect initially is insulin resistance. It's present early, and worsening is due to the inability to compensate by continuing to struggle to make enough insulin to overcome that resistance. What do we want to achieve? Well, there's certain tangible and surrogate goals. These are pretty obvious things. Prevent worsening. We don't actually know the best way to do that yet. We're doing a study at Iowa called the GRADE study, looking at different treatments for that. Prevent complications, good health, quality of life, minimize fluctuations in glucose, avoid costs, which may be very difficult, achieve normal body mass and physical activity. And the surrogate goals, mainly the A1C, which we use as the main indicator of control, blood pressure, lipid control, inflammatory markers, normal kidney function and liver function are all important so-called surrogate goals for diabetes. So before we go further into treatment, I'm going to just go over and review some important diabetes treatment trials that impact our thinking today. And some of these go back many years, some are more recent. This is a map here, and you can see at Iowa, we were one of these centers that did the diabetes control and complications trial. The main results were published in 1993, and since then we're still following the same group after the initial randomization period to intensive or conventional treatment. And we're still following them today in what's called the EDIC study. So this is what we did in the DCCT. This was 1980. I came to Iowa in 87, and the study was just beginning at that time, and we were randomizing patients. When I came to Iowa, it really wasn't clear to me whether or not it made a difference to control diabetes long term. So my major question was, did it make a difference? And to answer that, we randomized patients. This was a national study, 31 different centers. And you can see the goal for the intensive group was as low as we could safely get the A1C with not too much hyperglycemia. The standard group was targeted to about 9, which was the standard control at that time. And you can see the histogram shows the relative distribution of what was actually achieved. The average was about 7 versus about 9. And what was found in 1993, the study was actually stopped a year earlier than it was due to completion because of the marked positivity of the results. Retinopathy, if you didn't have any retinopathy before, 76% reduction in the onset of any signs of retinopathy based on fundus photography. 54% reduction in any onset of nephropathy, and 60% for neuropathy. This was during the randomization period. So at the end of that period, we then stopped randomization and recommended everybody go on intensive treatment and continue to follow the patients. But this goes to, before I get into that, this slide looks at the relative risk associated with the A1C. This isn't based on randomization, but trying to get the marker here to work right. Okay, but based on the continuous distribution of A1C versus the event rate per 1,000 years. And you can see when you have an A1C of 7 or less, you virtually don't get complications, at least during the period of the study. And even that seems to hold true in my experience today. I can't even think of somebody that's had A1Cs less than 7 over the years that's had anything other than maybe a microaneurysm. It gets a little worse as you get higher, and over about 8, it starts to increase substantially. So the initial randomization ended at about 9 years, and this looks at major cardiovascular events, the aggregate of non-fatal MI, stroke, or death from cardiovascular disease. And these are the difference in events. And at the end of the 9 years of randomization, there was no significant difference. The patients were 13 to 39 years at onset. So we weren't really expecting to see a lot of events. But as time goes on and we continue to follow them, even though the conventional patients have been started on intensive treatment, and they actually have both achieved about the same goal now, they're averaging about 7, 8. The difference in macrovascular events began to widen out and became significant after about 10 years after the end of the randomization phase, and continues to be different today, although the difference is not widening out, the difference is maintained. This is another study in England, the UKPDS, United Kingdom Prospective Diabetes Study, that looked at type 2 patients. And first of all, you can see this is the conventional intensive group, and they had targets of 7 and 6, but they didn't really adjust things too much at the time. They didn't really know what the outcome would be. But you can see that both groups worsened over time. This is some of the best data we have to show that diabetes type 2 does worsen over time. So they maintained a difference of about 1 point. And at the end of that period, which was the initial randomization period, they found that intensive blood glucose control by any means decreased micro but not macrovascular disease in patients with type 2. But as they went on, they found out that, again, there was a benefit on macrovascular disease. Except for metformin, even during the randomization period, in obese patients decreased the risk of an MI. And also blood pressure control proved very important. So these were the results longer term of the follow-up of the DCCT, the EDIC, and the follow-up, the UKPDS. So 9 years after the DCCT, the incidence of cardiovascular events was reduced 57%. These were in former conventional patients now on intensive therapy versus patients always on intensive therapy. And the same kind of thing was found in UKPDS. The patients that were treated with insulin or sulfonylureas had a reduction, 15% decrease in MI, 33% if they were the obese metformin group. And the mortality was also reduced 13 to 27%. Now here's some more recent studies that have cast some question as to what we really should target patients with type 2 diabetes. And this was with the CORD study, the ADVANCE, and the VA study. This we did here at Iowa and another 40-some sites, I think. The ADVANCE was done in Europe, mainly with some other countries in Canada, and the VA study here. So there's 10,000 plus patients in these studies with about 2,000 in the VA. The idea was the same for glycemic control. We achieved 6.4 versus 7.5 randomly assigned patients. In the ADVANCE, 6.4 versus 7, or 6.9 versus 8.4. Now, none of these studies showed any benefit in terms of preventing cardiovascular events, which was interesting. Now, these patients were at much higher risk for vascular events than the younger patients in the DCCT or in the UKPDS. They were recruited to be at high risk because if you're going to do a study in a reasonable amount of time, there has to be a risk for that outcome. Remember, in the DCCT, it took us 10 years after the 9-year randomization period, 19 years. These studies were done over about 5 or 6 years. So they saw no decrease. And what was of some concern is in the ACCORD study, there was actually an increase in cardiovascular mortality in the intensive group, which raised some concern, but I want to talk about that a little bit. This slide is what was found after they looked at the data a little more closely. So this is the risk over here, and this is the A1Cs achieved. This is intensive therapy, and this is standard. So the lowest events were in the intensive group that had achieved target. The standard group that was at target, in this case the target was 7.5, had the lowest rates. The intensive group at 7.5 had higher rates. So what this says is that the mortality, this is the risk of mortality, occurred in the intensive patients that did not achieve control. So what was the difference if you're here or here? You're at the same A1C. Well, the difference here is if you had an A1C of 7.5 in the intensive group, you were told to take insulin, take multiple doses, or it's probably more variation in the glucose, and perhaps patients vary. They might not have been motivated as much. So all these factors may have translated maybe to decreased motivation to do other things to prevent vascular disease. We don't really have all those answers, but the intensive patients under good control did not have an increase in vascular events or deaths. So these analyses, according to the Diabetes Care, ADA journal, American Diabetes Association, implicate factors associated with persistent high A1Cs rather than A1C per se as contributing to the increased mortality risk in the intensive ACCORD group. So the implications overall of these trials, the target of 7 as recommended by the American Diabetes Association is still considered valid. More aggressive treatment may need to be implicated early with cautious approaches in more advanced diabetes and cardiovascular disease. And I think this is the important thing. Overly persistent efforts to lower glucose in patients at risk for macrovascular events may not be warranted. There's strong evidence, however, for microvascular prevention. And again, type 2 worsens with time, and can we prevent this? That's an unanswered question as yet. So these are the treatment goals by the ADA, and this really reiterates what's on the last slide, but the ADA recommends an A1C less than 7 for non-pregnant adults. More stringent under certain conditions, short duration of diabetes. If you have lifestyle or metformin only, there's no point in saying, and I've seen some internists think this way, they have a patient that's on diet or with metformin, and they're on a 500 of metformin a day, and their A1C is 7.5, and they say, well, that's fine. But there's really no reason why you can't push that to get that under 7. And you should, because the metformin is not going to get you too low, and it's going to be a safe treatment. And clearly, you wouldn't tell somebody that's 7.5 to not diet. If you have a long life expectancy or no significant cardiovascular disease, then more stringent control, but less stringent with hypoglycemic unawareness, very important to avoid that, limited life expectancy, comorbidities, or long history of diabetes with minimal complications when control has historically been difficult. There are a few patients like this. So let's move on to more specific treatments now, drug therapy. Before I do that, this slide is not in your handout. I thought I should throw a word in about nutrition and lifestyle, which I don't have time to go into detail, but the point I want to make is that if you look at the guidelines from the American Diabetes Association and most other groups, there's really no longer any specific treatment for diabetes. We don't have the ADA diet, so to speak. And this is based on the appreciation that it really depends on other factors. And what we really should be doing is referring patients to nutritionists who can go over this in great detail. Difference if you're type 1 or type 2. If you're trying to match carbohydrates and sometimes protein and fat to an adjustable insulin regimen, then they need to know how to count and adjust. But if it's a fixed insulin program, some people just don't want to do this or can't do it. If the insulin dose is fixed, then the diet should be adjusted to match that. It can't be different every day. If you're trying to control blood pressures, lipids, if your activity is different, that can affect the diet recommendations. And then do you want weight loss? Do you want maintenance, or in some cases even gain? So you have to consider all these factors, and it gets back to the heading, no specific treatment. So let's move on now and talk more about drug therapy. There's metformin near universal acceptance. This is the first medication to use unless there's a reason not to tolerate it. It's in A1Cs of 9 or 10, it can reduce it by about 2 points. If the A1C is 8, maybe by about 1 point. Decreases the liver glucose release and increases muscle glucose uptake. Benefit on weight and lipids. Does not cause hyperglycemia. It's an insulin, makes insulin work better. So as your blood sugar drops, your insulin levels drop, and metformin is no longer going to be effective. So lack of hyperglycemia when used alone. It's generic. It's been used over 50 years worldwide, although in the U.S. since only about the 1990s. Evidence from several studies support a reduction in cardiovascular events, as we saw in UKPDS, and it's been shown to improve carotid medial thickening. And this is the UKPDS showing probably the strongest reduction for metformin in cardiac events. Now, in spite of all this use of metformin, there's really no consensus as to how it works. We know it reduces hepatic gluconeogenesis, so decreased fasting liver glucose output is probably the major effect, with a secondary effect to increase muscle utilization. But how it does that is still unclear, and I'm not going to go into detail here, but I've listed some potential biochemical mechanisms here that have to do with mitochondrial function, or something called AMPK, or phosphate kinase in cytoplasm, or some other mechanism. And there's a lot of work being done to sort this out, but nonetheless, the drug is still achieved tremendous status as the most effective initial treatment, or the most recommended initial treatment. I shouldn't say most effective. Insulin can be more effective. So what do we do in an algorithmic sense? As we said, metformin, the initial approach, unless you start with severe hyperglycemia. So if a patient with type 2 comes in with symptomatic hyperglycemia, or blood sugar is over 300, unless they've been doing something crazy like having 5 bottles of soda pop a day, which you can easily stop, most cases I would really start with insulin. And not necessarily use it forever, but if they're presenting with high enough glucose, controlling the blood sugar with insulin to protect them. For all I know, they may have cult type 1, but getting them under control, and then if they do well, you can back that off and even stop it. Metformin otherwise would be the initial pharmacologic treatment. Goal achieved or not achieved, or whether there's intolerance to it, just add another drug. The question is now, what drug do we add? And that's something that is under considerable debate, and we're doing there's studies ongoing to look at that. As you know, the FDA has approved many new drugs for type 2 diabetes that one could add. So what about sulfonylureas? This is the inexpensive, time-tested way to do it. They increase beta cell insulin secretion by activating potassium channels. Glyburide, which was used abundantly a decade ago, we tend to get away from that now, mainly because it causes more hypoglycemia and seems to have more effects on cardiac sulfonylurea receptors, and that might actually be adverse to the heart. But instead, we are focusing on glipizide, which is shorter acting and perhaps causes less hyperglycemia, glimepiride, which in my experience is a little more potent and longer acting. So these two are used widely. They're well tolerated, they're low in cost because they're generic. Disadvantage, hypoglycemia. And I've seen a fair amount of that, especially if it's pushed too hard in mild type 2 diabetes. In fact, in some ways, it's harder to control than insulin because you can adjust insulin better. Weight gain, if you're not watching the diet, it's really you're trying to replace the insulin that the person can't secrete. So in theory, they wouldn't gain more weight than they would if they didn't have the diabetes. But people don't watch the diet and they control the glucose. They're no longer wasting glucose in the urine, so they gain weight. This is something that's often overlooked. This is actually a contraindication, sulfa allergy. Most of this is antibiotic sulfa allergy, and I've never really seen somebody with a mild sulfa reaction get put on a sulfonylurea and have a problem, but I don't use it when there's a significant allergy. And it may have, we don't know about the durability. It may be that maybe these agents that stimulate insulin exhaust the pancreas faster over the years and you get a low durability of action or maybe worsening. But we don't really know that. That's one thing we're looking at in our grade study at the university. Cardiovascular effects. There were studies in the 70s that I remember was a student that was called a University Group Diabetes Program, and they increased cardiovascular mortality. This happened in only 2 of 11 or so centers that did this study, so that was argued for years. But now we know from several other studies, including the UKPDS Advance and Accord, do not support a risk of cardiovascular disease due to sulfonylurea. So that's pretty much set aside in terms of clinical evidence that they have bad cardiovascular effects. Although, as I said, we do worry a little bit about glyburide and cardiac receptors. What about these newer agents? So now we have abundant new products available. DPP-4 inhibitors, and as you know, there's several of these available now. Which one's best, I don't know. Mostly, this is the first one out and has been used quite a bit. They block the degradation of endogenous GLP-1. That's the hormone from the gut that tells the pancreas, hey, the person just ate, get ready to make insulin. So they increase insulin secretion when somebody eats, but not when they don't. They're not very effective in my experience. I see A1Cs drop by about 0.5 point. A lot depends on how well the patient's diet, but they don't seem that effective. Advantage, they basically don't cause hyperglycemia. They stimulate insulin when you eat and not otherwise. Disadvantages, I haven't seen much of this, urticaria, angioedema. There is supposedly a pancreatitis risk. I've never seen that, but it is out there. There's no evidence that clearly associates it with pancreatic cancer, although there's websites that talk about that and scare people away. Cardiovascular effects of the DP4 inhibitors. They're weight neutral. They don't decrease appetite. They decrease triglycerides, reduce the CRP, inflammatory effect, and they in rodents they can actually decrease ischemic reperfusion. That's a way of looking at vascular perfusion of the heart and carotid thickening. There have been a couple of large cardiovascular outcome studies that showed no difference in cardiovascular outcomes. Mainly these are heart attacks, strokes, and non-fatal MIs, but some of these studies add in peripheral vascular disease or angina and other factors. The large TCOS trial, almost 15,000 patients, sitagliptin or placebo, showed no difference in events. So really neutral in terms of cardiovascular effects. And what about the GLP-1 agonist? And you've heard of these. We now have short and long-acting forms of these drugs. They're injectable, either twice daily for Byetta, once daily for liraglutide, or weekly. You can get a long-acting exenatide. So these activate GLP-1 receptors in the beta cell. They're agonists of GLP-1. GLP-1 has a short half-life, only minutes, and that's what the DPP-4 inhibitors do. They prolong that half-life. Here we're actually giving an analog of GLP-1 that's more stable and can be stable up for a week in some of these cases. They decrease hepatic glucose output and decrease postprandial glucose. They also decrease appetite, which is an advantage of these agents, and are associated with mild weight loss. In fact, liraglutide at a dose of 3 milligrams per day as opposed to 1.8, which is the maximal diabetes dose, 3 milligrams a day is approved for weight loss therapy, as I believe you know. And even on the 1.8 in diabetes, patients generally, in my experience, will lose a lot. Not a major amount, but a few pounds, maybe up to 5%. They can cause nausea, vomiting, diarrhea, pancreatitis risk, not pancreatic cancer. And there's evidence that they're not good if you have a medullary thyroid carcinoma, which is a complicated reason for that. But that's a pretty rare kind of thyroid tumor, but does occur and should be considered when you're starting these agents. Do they help the cardiovascular system? Well, there's evidence that they do. There's two major trials, the LEADER trial and SUSTAIN trial. First, they have favorable effects: decrease weight, fat, blood pressure, increase urine sodium output, so you're decreasing salt retention, improve endothelial function, and improve lipids. So this was a big study. The LEADER study just published a few months ago, 10,000 patients. They showed that the composite outcome occurred in fewer patients. Not a huge difference, but that's about a 15% reduction in risk. And SUSTAIN 6 showed a similar thing, and that had a risk of 8.9 versus 6.6 in the GLP-1 agonist group. And here I just show you the outcomes here, and you can see the outcomes are not markedly different, but there is significance in terms of the number of events. This is for the primary outcome, the aggregate outcome, death from cardiovascular disease, and this is myocardial infarction, stroke, hospitalization for heart failure, or death from any cause. So they're mildly positive effects that did achieve significance with large number of patients, not marked effects. So what about the newest group, the glucose cotransporter 2, sodium glucose cotransporter 2 inhibitors? And these are advertised on TV a lot now. We have 3 of them out there, and they work by basically helping the kidney excrete glucose. So normally you reabsorb glucose in the proximal tube, and the neck is mediated by a protein called SGLT2, sodium glucose cotransporter. This is blocked, so you don't reabsorb the glucose, and it ends up being excreted since this is normal. In the absence of that, it's high. And that'll help higher glucose more than lower glucose, because as the glucose gets too low, you normally don't excrete glucose, so you don't get hyperglycemia from these. The A1C is going to drop by about a point, usually is what I've seen, but similar at the A1C of 8, if it drops by nearly a point, that's about what metformin would do at that level. The advantages is hypoglycemia is very unusual because as glucose drops, there's nothing to excrete. Interestingly, we've known for a long time certain people have renal glycosuria as a defect in that, a natural defect in SGLP2. And this is a benign disease. They don't get in trouble. I don't know of any data to see what their incidence of diabetes is, but I bet it could be less. You can combine this with other agents because it has a unique action, and it does appear to have cardiovascular benefits. I'll show you something about that. But there are disadvantages, and this probably is more worrisome in women. UTIs, vulvovaginitis, balanitis, osmotic diuresis, even DKA has been reported. And the liver actually puts out more glucose, as it almost is like it's getting some signal. It's trying to compensate for the glucose being lost. And this is the difference in A1C over time and with an empagliflozin study. And you can see that even at 10 milligrams, there was a fair difference. So what about the cardiovascular effects? Well, by inhibiting salt reabsorption, blood pressure will drop. There's weight loss of not a lot, but 2 to 3 kilograms over 6 to 12 months, and it seems to persist for 2 years. There's small increases actually in LDL, but also HDL cholesterol, decreased uric acid. There's data from meta-analysis showing that cardiovascular is reduced with a rate of 0.82 for the hazard ratio, somewhat better than for the leader studies. The big EMPA-REG study was about 7,000 people, and that was just published that was actually a little more than a year ago, but it did show decreased hospitalization for CHS and favorable cardiovascular effects. So this turned out to be about the same as the meta-analysis. And what about this DKA you hear about? I haven't seen this in my experience, but we only see so many people on this drug, and it may not be recognized because the glucose is not going to be as high. So you're really lowering glucose without doing anything to insulin. So your risk of DKA may occur at a lower level, so it may not be so obvious. Patients aren't checking ketones. We don't know why it occurs, but there's some thoughts that it increases glucagon and maybe decreases insulin because there's not the need to control that glucose. Increased reabsorption of ketones, shift in substrate utilization, weight loss, dehydration from loss of fluid. All these can contribute to the risk of DKA. So we do see that sometimes. I would think, and I've not really seen data, that this would be higher if you use it in type 1. And there are people that are trying to use it now as a type 1 drug, thinking that it'll just make it a little easier and you can lower insulin perhaps more safely because you can get the blood sugar down lower by decreasing the amount of glucose without having to give as much insulin. And that may or may not work, and I'm really not seeing conclusive information about that. So I'm reluctant to use it in type 1, but I know it's being looked at. And this is the kind of difference you get with the outcomes. A little better perhaps than the leader study and SUSTAIN that looked at the SGLP, the GLP-1 inhibitors. And just to show you by comparison, this goes back to that old data. This is the DCCT results from 1993, where we showed a 76% reduction in retinopathy. And this is patients that had retinopathy if it worsened. Huge effects versus relatively mild effects in some of these other studies that we looked at. So you don't see this very often. Other drugs for type 2 beyond metformin, is really used less. The ropaglinide and the teglinides, I don't really use these. I don't find them very effective, actually, but they are shorter acting, and for people with mild diabetes, they might help postprandial glucose without having a prolonged effect. And I stay away from the thiazolidinediones. I really worry a lot about congestive heart failure and fluid retention. I've just seen a lot of that over the years, and I've seen patients with severe CHF do much better when these were withdrawn. So this is still debatable. Whether or not they cause MIs, that was what was reported for rosiglitazone, but that's come into some question now. These are used, alpha-glucosidase inhibitors, again, not very effective. And bile acid inhibitors may decrease glucose too by decreasing absorption of, but they can also decrease absorption of other medications and increase triglycerides. Bromocriptine is interesting. It has a central nervous system effect. I have to say I've not used this for diabetes, but this perhaps needs a little more study. Can we act at the central nervous system to improve glucose? Because we know there are signals from above that regulate glucose. So we'll move on now to insulin, the appropriate use of insulin. Advantages, it's natural, it's perhaps less expensive. Well, that really has to go off the boards now because they've raised the price so much that it's ridiculous. But if you use NPH or regular, which are the best insulins, you can get by with cheaper cost. Once daily for patients, some patients with type 2, less weight gain than TZDs. I don't think you get as much fluid retention. And apart from hyperglycemia, there really are not side effects if you visualize this as a natural treatment. But if you don't watch your diet, just like the sulfonylureas, you'll stop losing glucose in your urine and there'll be weight gain. And of course, you have to inject. Does insulin impose a cardiovascular risk? This has been talked about. And basically, I strongly believe that it does not. There was a big study in the UA. They looked at 165,000 patients epidemiologically by looking at records, and they applied, I don't know what these structural models were, but they corrected for comorbidities. So basically they're saying people that get insulin have worse diabetes, they have other associated conditions, they're sicker people, and that's why they're on insulin, and that's why they have more events. When you control for those things, that is not seen. And in the DCCT and the UKPDS, when we did not see that. We saw in the DCCT that we used more insulin for the intensive group and saw less cardiovascular events. So after adjustment for baseline covariance, no significant association of insulin with cardiovascular risk in the ACCORD study, a more recent study. So things to keep in mind, insulin can increase salt retention and stimulate the CNS, but it's also anti-inflammatory, antioxidant, profibrinolytic, and cardioprotective in patients with acute MI. So overall, it does not induce ASCVD when administered properly for diabetes in humans. You can see other things in cells in certain animal models. And of course, you want to achieve target, which sometimes only insulin can do. So what kind of insulin do we have? I think you're familiar with these insulins. Quick-acting insulin, Lispro or Aspart, regular, which we had used until 1995, is the only short-acting. Peaks later, about 2 to 3 hours later versus an hour, and lasts longer. NPH is more of an up-and-down effect. Glargine has the advantage of being long-acting, over 24 hours, although in some patients I give it twice a day because it does seem to have an earlier effect in the first 12 hours in some people. Same with Detamir, it's even shorter acting, and often that'll be used twice a day. And now we have the new one, just came out, Degludec, which lasts up to 42 hours. So you're overlapping one with the other because it's given every day, but the manufacturer claims you have a more sustained, more steady effect. And I can't comment on it clinically. I haven't used much of it. I'm sure the cost is high. So insulin regimens can be simple, once or twice a day for people with type 2 that are mild. Complex can be a basal and bolus program like you would for type 1 if there's not enough insulin being made in severe type 2 or type 1. So it depends on the severity of the diabetes. So how do you, when a resident asks me about how to control diabetes, I just like to tell them that for type 1 and severe type 2 where there's very little insulin, I can tell you how to do it in one sentence, and that basically is give insulin the way the body would make it if it could. Another way to say it is think like the pancreas. So this is a study that was done in the 70s, just before the DCCT started, and it basically looked in 6 patients, and this is the plasma glucose, normal people, no diabetes, over 24 hours, and this was the range. And you can see that, as you'd expect, it goes up after breakfast, lunch, and dinner, and stays at a basal level of about 80 to 100. So this is glucose, and you can see this is achieved because insulin spikes with meals and with a bedtime snack. And so what we want to do is mimic that. So we want to use basal insulin to mimic that. That would be your long-acting insulins. And very simply, bolus insulin. So basal bolus programs. Insulin dosing in type 2, we'll go over this, to keeping in mind we want to do what we can to mimic physiologic insulin. But in type 2, if you can just give a single long-acting dose, that may actually rest the pancreas overnight, and there may actually be better pre-meal insulin. So type 2 is not an insulin, except in severe patients. There's still a fair amount of insulin being made. So you can often do it with a single long-acting dose. It doesn't mean it's not physiologic in that setting. So it's hard to know actually the best starting dose. In the study we're doing, if the A1C is under 8, we'll start with 10. Over 8, we'll start with 20, but another way is 0.2 units per kilogram. But really, it's more a matter of adjusting what happens over time. So with a stable glucose and lower A1C, you may only need basal insulin. You can start with a low dose, but large amounts may eventually be needed. Keeping in mind that if you start with 10 units or 20 units, some of those patients will be so resistant you can end up treating them with 300 or 400 units. So you can't just raise it often. Just if you start by raising it a unit or 2 every time they have a higher blood sugar in the morning, it can take forever to get to where you're going. So you have to make adjustments in how you want to make increments in insulin over time. You may need large amounts in sick patients due to stress, steroids, or tube feeds. And in severe, as I said, insulin deficient type 2, it's more like type 1. So you're going to go to basal bolus. This was a study that looked at the effect of just looking at the morning blood sugar and then increasing basal insulin according to that. And they compared glargine with NPH. And they had an algorithm. If the blood sugar was so high, you incremented the insulin by a few units. And what they found is that glargine and NPH had the same effect on fasting glucose and A1C over about 24 weeks. However, glargine achieved this with less hyperglycemia. So this was the incidence of hyperglycemia. So that's because it's smoother acting than the longer acting than the NPH. Insulin dosing in type 1, again, we want to mimic basal bolus programs, roughly 0.4 to 0.5 if you want to start with something. But more important than what you start with is to monitor it carefully. If I have a new patient with type 1 and they're relatively stable, they're not anywhere near DKA and they can adjust and monitor, I'll start with even a lower dose and just adjust it. And what I find is often in the first several months of their diabetes, they'll go into a remission phase, so-called, quote, honeymoon phase. And the insulin dose, they sometimes can get hypoglycemic even on small doses, as little as 10 units. So I think they also seem to have a greater sensitivity as you start treatment. But I kind of watch for that. The typical adult with established type 1 needs about 40 to 50 daily, but that's variable. It may increase with activity and eating, obviously. Overweight, or vary with eating and activity. Overweight, obese type 1s, which there's plenty of them out there, may require larger dosing. And keep in mind that if type 2 diabetes affects about 8 or so % of our population, and another up to 20% or so have pre-diabetes, then that's going to apply to people with type 1 diabetes. So you're going to have a lot of people with type 1 and type 2 who might be very insulin resistant. So MDI or pump insulin, how do you start? Basal bolus can be obviously through injections or pump. Approximately half of the total dose should be given as basal insulin. And that can vary. If somebody's having a very low carbohydrate diet, they may not need as much bolus insulin. If somebody's very active, they may need less basal insulin. So you have to really consider all these factors. But on average, if you have somebody that's getting 80% of their insulin is basal and a small percentage pre-meal, unless they're completely avoiding carbohydrates, they're probably not controlled well. They're probably getting hypoglycemia between meals. So you want to look at that ratio. So you can give glargine or detamir either at bedtime or may need to change to BID. And bolus insulin is divided between meals. It's not like you start seeing somebody in the clinic, I've had residents say, well, I'm going to start basal insulin, I'm going to give about 20 units, and I'm going to give bolus insulin another 20 units, and I'm going to give 7, 7, and 7. And I say to them, well, how do you know that they're going to eat in a way that's going to require the same amount of insulin at each meal? And they say, oh, I hadn't thought of that. So you have to talk to them about how to do it. It's not just saying take insulin this way. That usually will not work. Most people don't eat the same at every meal. And it's not just carbohydrate. A lot of protein or fat will prolong the effect of the insulin or prolong the duration of the hyperglycemia and can require more insulin over a longer time. So bolus dosing, you can have a fixed schedule if you keep the meals constant, which a lot of people don't do or don't want to do, but if they can't adjust because of various psychosocial reasons or inability to do it, then it's best to keep the carbohydrate and perhaps fat and protein constant at meals as best you can. But they can't eat every day the same way. Better to estimate the carb intake and determine the bolus dose based on the grams of carbohydrate. And keeping in mind that if you have pizza with a lot of fat or a lot of cheese on it, it's going to require more insulin for the same amount of carbohydrate than if you had pizza with low-cal cheese or no cheese. And that's actually been studied. So ask patients about their eating habits and accommodate them to the extent reasonably possible. And correction insulin. Well, this looks complicated on the slide, but it's basically saying if your blood sugar is high pre-meal, then take more insulin. And you can use the so-called rule of 1800, which actually, before I came to Iowa, was at a diabetes center in Atlanta, and I want to brag because the guy that started that center, not me, I came down and was recruited by him, he came up with the rule of 1800. Never published it, but used it in 1980s. And it's caught on and appears in lots of texts now. You take the total daily insulin, let's say it's, if you have a total daily insulin of 50 units, you divide that into 1800, and you get a number which is a sensitivity. So if you're on 36 units a day, then this Y is 50, 36 into 1800. And then the high target is 150, so for every 50 points above the 150, you add 1 unit. The sensitivity is 50, drops it by 1 point. That's all very complicated to some patients, so you just write a scale. And pattern adjustments. Let's take a look at this. If people write their glucose down and they come to you with these numbers, you look at this morning glucose and the noon glucose, and this is what they've taken in the morning, it's hard to make a lot of sense out of that. You look at this and you say, well, these are different doses. How can I see anything? But if you tell them to write it like this, now you can see they've taken 7 units and they've adjusted. So if you consider for a moment that the adjustment is right, then obviously their 7 is not enough. So they need more. But if you wanted to be more careful, you have them do a 9 a.m. glucose a couple hours after eating, and you see that that's high. So that they need more insulin. The 7 is not controlling them postprandially or at noon. But if that 9 a.m. glucose were this, that's a different story. Now you can see the 7 is lowering them fine, but they're rising before noon. So what are they doing? Are they snacking at 10 o'clock? Are they not getting enough basal insulin? So you need to consider this. So you can take these glucose spreadsheets and look at them in a very careful way if you get enough information. Now people aren't going to measure this every day, but you can do periods of time where you ask them to check a little more often and see what happens, sort of do an experiment with the patient. And adjusting for exercise is difficult. It's basically individualized. You have to either take more calories, which is good if you're trying to use the exercise for weight, or you can sometimes reduce the basal insulin, or if you have a pump, you can reduce the pump insulin basal rates temporarily using a temporary basal rate. So we'll talk about types of insulin. This is now much different than it was when I started, where we had NPH and regular insulin, and even something called ultralente, which I almost forgot about. But this is what we had until about the 1990s, when in 1995 we got Lispro insulin. And now we have fast-acting insulins and long-acting insulins, and now even the Degludec. And new preparations, and we have stronger insulins. We have U500, U300, U200, and we have pre-mixed insulin. So it's pretty complicated. Now, what does I ask residents, what does U100 mean? And they don't know that. Nobody ever taught them in medical school. And I don't know that everybody in the audience here really appreciates this. Some of you it's second nature to, but what does U100 mean? It means there's 100 units per ml of insulin. And realizing that the only syringes available pretty much are U100 syringes. And so if you took an insulin that's U500, 500 units per ml, and you draw it up in a U100 syringe, you're going to get a big overdose if you just look at that number. So you have to be very careful about what those U100 or U500 mean. And the reason we need U500 is a U100 syringe can only hold 100 units. If your patient's taking 200 or 300, they might be better off with a more concentrated insulin. And this is the new insulin degludec, duration 42 hours. Whoops, sorry. And basically it's a longer acting insulin. It's been modified and maybe gets less hyperglycemia based on the manufacturer's trial. Again, something just new, and we're going to have to see what happens over time. This is a picture just of the concept of U500. This is a U100 syringe. The person's taking U100 insulin. They draw it up to 100. They get 100 units. If they're taking U500 insulin, they draw it to 100 to 20. They're drawing it to 20, but they're getting 100 units. It's 500 units per ml. So to get around this, this is coming out in pen form now, where the pen is accurate in dispensing it. And that's how it should be done, in pens. Hospitals won't allow the pens in hospital because they're worried the insulin syringes will be used in different patients. Or even with a different needle, there could be contamination of the contents of the pen, and they're worried the pen will be used in some other patient. These can be, U500 can be used in pumps, and we do use it. So this is U500. It's now available in a pen form and can deliver up to 300 units in a single injection. These are other concentrated insulins. Glanthus is now available at U300. It's glargine. They gave it a new name of Tugeo. Luigi. I'm not even sure how you pronounce it. Tugeo is, I think, the more common one. U200 Lispro is available, and degludec is available in 2 concentrations. So in the time left, we'll talk a little bit about pumps. This is the Medtronic pump we've used for years, the MiniMed. Well, this is a new version of it, but for years we've used the Medtronic pumps. It used to be MiniMed, now it's Medtronic, but now they've come out with a new pump that I'll talk about a little bit called the Medtronic MiniMed 670G. But these pumps are estimated about 40% of patients with type 1. I don't know if we're that high at Iowa, but that's what it is nationwide. Can be used with a sensor and requires changing the needle every 3 days. Convenient, better control of basal insulin. Indications, it's not like the patient has to be under poor control. If somebody with type 1 doesn't make insulin, wants to use a pump, I consider that an indication because it's more convenient for a lot of people. Sometimes cost, unfortunately, is a problem. Patient does need to be educated to use it effectively. So this is the first pump, 1963, and actually worked, and basal bolus insulin was given to this guy. And this is today, and we have pediatric patients using MiniMed pumps with real-time glucose sensing. So this measures the blood sugar every 5 minutes, and what we have now that's commonly used is pumps that will turn the insulin and basal insulin off if the blood sugar drops below a preset level. So that is an improvement with glucose sensing now interacting directly with pumps. It'll alarm also for hypo or hyperglycemia, and it links nicely to certain computer programs. This is the real-time continuous sensor, the Paradigm model, which feeds back to the pump, and will turn the pump off if it's set at a certain level. And that's called threshold suspend. So that's now available in the MiniMed 530 system. And you get this nice CareLink software which you can get and download and have the patient use it, and you can have a code that you can see what the patient's doing online. You get nice printouts of the blood sugar mean and variations day by day, pre-meal glucose, and several indications of how much insulin they've taken, when they've taken it, and what the glucose has been. So lots of information in CareLink software. Here's the so-called modal day, where all the glucoses by finger stick are placed as if they were on one day and helps look for patterns. And then this is the new one, the 670 Enlight, which is now, which will be available in April. And I have a patient I just saw the other day that's planning to get one. This takes the sensing and closing the loop just a little further. It's not a real closed loop system, but what it will do is adjust the basal insulin according to the blood sugar. So not just turn it off at a certain preset threshold for being low, but continually adjust the basal insulin. And that hopefully will be quite a bit of an improvement, because it should give you almost a continuous source on your basal insulin. It's got certain safety features in it so that it doesn't overdo it. And it does depend on the sensor working reasonably well, so that needs to be monitored. It does not affect bolus insulin. You can't adjust that with the sensor. And this is something that's not available yet. You'll read about the artificial pancreas, and it's really for future use. And what this does is it senses and gives both insulin and glucagon, and people are trying to put this into one pump. And the studies have been done. They've had 2 separate pumps. And the sensor not only adjusts the insulin continuously and also adjusts the bolus insulin, but also adjusts insulin and glucagon. So here's they did a study. This is the blood sugar over 24 hours, and this is the interstitial glucose, which was done by the sensor, which tracks it very well. And here's the glucagon was injected, or insulin was injected. Depending on here, the blood sugar is high, they give insulin, and the blood sugar comes down, so they give glucagon. Patient's not eating, needs a little more glucagon, eats, gets more insulin, a little more glucagon, etc. And they can monitor the plasma insulin and glucagon. So there's some nice articles published here if you wanted to look at that. Russell and Diabetes Care, it goes back to 2012 when this was first done. But this is not yet available, but something we're working on hard. So last slide is sick day management. And what are the goals, and why do I include this? Well, I see this happen. I hear of cases where the patient with type 1 diabetes is called up and said, "Doc, I can't eat. What do I do with my insulin?" And this is common, and an uneducated resident will answer this call the wrong way and actually can cause DKA, because the last thing you want to say is, "Don't take your insulin." You have to remember the overriding message is patients with type 1 diabetes or severe type 2, they need basal insulin. They will go into DKA even at normal blood sugars. So you want to maintain hydration, prevent ketosis, control the glucose. So you need to obtain information. Are you alone? Are you alert? Can you get to a hospital? If you live down the street from the hospital here, then fine. But if you're out in a farm 30, 40 miles away, you may not be able to get here. So all these things determine my threshold. Can you check ketones? Can you hold liquids down? That's very important. If they can't hold liquids, if they're at a distance, if they don't know what their ketones are, if they're alone, these are all reasons I would say come to a hospital. If they're stable and they're able to do these things, and they can get here if they really have to, and somebody's with them, you can do a lot at home. If they're having severe, large ketones and feeling sick, they should come to a hospital, especially if they can't hold liquids. There's nothing they can do. They're just going to dehydrate further if they can't hold liquids down. So you have to get them to, if they can't eat, have at least 4 to 6 ounces of liquids per hour, non-caloric, unless the blood sugar gets down lower than about 250. Then they can maybe have some caloric liquids with insulin. Try to get the calories if they can eat, fine. Take the basal insulin. Don't stop the basal insulin. What do you do with meal insulin since they're not eating? Well, basically, you need to have them checked frequently, about every 3 or 4 hours, and use correction insulin. And maybe you need more. I'll often tell them to take 1.5 times their usual correction amount. That's that sensitivity factor amount, or sometimes twice that amount. But again, we talked about reasons to go to the ER, various things you need to obtain in history and ask about these things. And I try to teach our residents to do these things, and it's amazing how often it's forgotten. So that's it, and I'll stop here and thank you for your attention. I think we have some time for questions. Rick?
Yeah, thanks a lot. It was great. I saw a couple mentions of the inhaled insulin. Could you just touch on that? Have you had any experience or use of that, and what do you find use for it?
What kind of insulin?
Inhaled insulin.
Oh, inhaled.
Yeah.
We did a study of the powder years ago, and they tolerated the powder. Truthfully, I have never prescribed inhaled insulin. I've read a lot about it. I've talked to people that have tried it. They've come to me after using it. and I just can't make myself use it. I just don't think it's very, I worry about its effect on the lungs. You can't accurately dose. I think for type 1 it's crazy. You can't dose it accurately. And I'm scared of it, to be honest. And why isn't it selling it? Why is it went off the market? I think it's coming back now, but initially the first attempt to market it, people stopped using it. It was too hard to use. Same thing with they have this sensor, this glucose injector, the air injector. It's never sold. It's still available, but nobody buys it. People, once they've injected, they realize how easy it really is. So that's my answer. Okay. All right. Great. Thanks.